हाय गाइस, वेलकम टू माय चैनल। आज का हमारा मेजर टॉपिक है हाइपरटेंशन। आज के वीडियो में हम हाइपरटेंशन के कॉजेज़ डिस्कस करेंगे, इसका ट्रीटमेंट, इसकी पैथोफिजियोलॉजी और डायग्नोसिस। सो फर्स्ट ऑफ ऑल वी शुड नो व्हाट इज़ द हाइपरटेंशन। Here they have mentioned that the definition of hypertension, which is the persistently elevated arterial blood pressure. They have mentioned it's a persistent elevated arterial blood pressure. The seventh report of JNC, which is which tells us about the classification of the hypertension, and we have discussed it in a table. Here the table is this one. You can see here there are 4 classification of hypertension. Number 1, normal. Number 2, prehypertension. Number 3, stage 1 hypertension. Number 2, stage 2 hypertension. So when the systolic blood pressure is less than 120, it's mean it's normal. Less than 120 or it's 120, so it's mean it's the normal one. And when the systolic one is 80, it's normal. So 80 by 120, we consider it as a normal blood pressure. The second one is when the blood pressure reaches to 120 to 139, as you can see here. When blood pressure reaches to 120 to 139, then it's called prehypertension in case of systolic, and when it reaches to the 80 to 89, then it is prehypertension for the diastolic. So if the blood pressure is 130 by 80 or 130 by 89, then it's mean it's a prehypertension. Then the stage 1 hypertension is 140 to 150, is a stage 1. When the systolic is 140 to 150, or diastolic is 90 to it's approximately 90. You can undo it. It's approximately 90 to 99. And stage 2, when greater than 160, then it's called the stage 2 hypertension. So we can drawing it here. These are the types of hypertension. Number 1 is normal, when the systolic and diastolic blood pressure will be less than 120 by 80. And the second one is a prehypertension, when systolic is 120 to 139 range. It's mean when the blood pressure is 120 by 130 by 80, then it's prehypertension. And as the stage 1, when there is a blood pressure reaches to the 150 above 140. So when the blood pressure is 150 by 90, it's mean it's a stage 1. And when greater than 160, it's and greater than 100, it's a hypertension stage 2. So when we measure the hypertension, if it's like 140 by 80, so we can say it's near to the prehypertension and stage 1 hypertension, 140 by 80. So if when we know the types of hypertension, then we can when we know the type of hypertension, we can treat it accordingly. If it's prehypertension, we don't need to give any medication. We can control it by the lifestyle modification. And when it's stage 1, then we should give some kind of medication. And when stage 2, then another kind of a medication. We'll discuss it later. So it's all about the hypertension. When someone asks what is hypertension, so it depends on the classification. It's normal one, prehypertension, stage 1 and stage 2. So here the two main points are, I'm here. What is a isolated systolic hypertension? Isolated means the single one. So the isolated systolic hypertension means when the diastolic blood pressure is normal, like its value is less than 90, but the systolic blood pressure value is 140 millimeter high or more. It's only the systolic one which is higher. See, the systolic pressure is greater than 140, but the diastolic one is less than 90. Then we can say it's isolated systolic, or we can define in this way the isolated diastolic when the diastolic blood pressure is greater than 90, but the systolic pressure remains same or less than 130. So isolated systolic hypertension means the systolic pressure is high but the diastolic one is low. So it's important definition. We should know that what is the isolated systolic hypertension. And another one is here is hypertension crisis. Hypertension crisis occur when the blood pressure is greater than 180 by 120 millimeter angiogram, means the systolic and diastolic one. So if the systolic pressure is greater than 180 and the diastolic reaches to 120, then it's the hypertension crisis, is the emergency condition. So here they can categorized as a hypertensive emergency, extreme blood pressure elevation with acute or progressive target organ damage. When the blood pressure reaches at this point, when it's like 180 by 120, so your organ can damage. Or hypertensive urgency means a high blood pressure without acute or progressive target organ injury, means there two conditions, maybe the organs damaged, maybe the organs not, but in both cases this is the emergency or urgency condition. So hypertension is not a minor ailment. It it can lead to the death or damage to the organs. In pathophysiology, we are discussing the cause of hypertension. What is the specific cause? If the hypertension goes from a specific cause, here, if it occurs by a specific cause, then it is called as secondary hypertension, or or from unknown etiology. If the unknown etiology, then it is called primary or essential hypertension. So the primary or essential hypertension may be caused by the unknown etiology, or the secondary hypertension is caused by the specific one. The specific one causes a secondary hypertension, or primary or essential hypertension may be caused by the unknown etiology. Secondary hypertension, less than 10% of cases, is usually caused by the CKD, chronic kidney disease. If the person is suffering with the kidney problem or having kidney injury, then he definitely suffer with the hypertension too, which is the secondary cause of the hypertension, or renovascular disease. So these are the secondary causes of the hypertension. So other causes may be if the person have Cushing syndrome, or aorta problem, obstruction of the sleep apnea, hyperthyroidism, pheochromocytoma, primary aldosteronism, and hyperthyroidism. These may be the secondary causes. Some drugs that may increase the blood pressure include, this is the important point, sometimes the patients are taking medicines and those medicines are responsible for increasing the blood pressure. So if the patient is already a high blood pressure have problem of the high blood pressure and is taking these medicines, so their blood pressure can be worsened. So they have to check and balance and have keep an eye on the blood pressure when they are taking such kind of medicines like corticosteroids, estrogen, NSAID, non-steroidal anti-inflammatory drugs. So there is a drug interaction between the blood pressure and NSAIDs. NSAIDs is a commonly used medicines in our daily life. Like we are using different kind of and like aspirin. These are the like painkillers. So painkillers we are using most commonly, and they are responsible for increasing the blood pressure too. So we have to keep an eye on the blood pressure when we are taking any kind of the painkiller. Amphetamines, sibutramine, cyclosporin, tacrolimus, erythropoietin, and venlafaxine. These are the drugs which are responsible for increasing the blood pressure. Like aspirin, diclofenac sodium, ibuprofen. We commonly use the ibuprofen, diclofenac sodium. So if the person is high blood pressure, having the high blood pressure and taking these kind of diclofenac and ibuprofen, so he or she has to keep an eye on the blood pressure and record blood pressure carefully. Factors contributing to development of the primary hypertension include, अब यहाँ पर हम आपको बताएंगे कि कौन से factors हैं that are responsible for increasing the primary blood pressure. So these are the factors. Number one is humoral abnormalities involving the renal angiotensin aldosterone system. So, if there is any abnormality in the renal angiotensin aldosterone system, which is RAS, we can call it RAS, which is the renal angiotensin aldosterone system, natriuretic hormones, and insulin resistance and hyperinsulinemia. So, if there is an insulin resistance, this is the important mechanism about the insulin resistance. We will discuss later what is the insulin resistance and how the insulin resistance affect your body. Sometimes insulin resistance occur and your body is gaining weight. So it's the very important thing. What is the insulin resistance? Hyperinsulinemia means there is increase in insulin. So if there is an abnormality in renal angiotensin aldosterone system, natriuretic hormones, or insulin resistance, or hyperinsulinemia, in every case, there is a chance to increase in the fluid content, and when there is an increase in fluid content, and there is increase in the blood pressure. Second point is disturbance in the CNS. If there is a central nervous system problem, autonomic nerve fibers, adrenergic receptors, or baroreceptors. We are saying in our in daily life that if the tension causes the blood pressure, high blood pressure. So tension means anything that happen in brain. So CNS is the major thing that is responsible for increasing the blood pressure. If there is any condition like anxiety, there is a fear, anxiety, and the adrenergic receptors are activated. So these high adrenergic receptors mean there is increased release of the adrenaline and epinephrine, which causes increase in the blood pressure. So central nervous system disturbance, autonomic nerve fibers disturbance, adrenergic receptor baroreceptors, these are the responsible for increasing the blood pressure, and they are the our daily everyday causes. The daily causes means that happens in our daily life, like any tension cause the high blood pressure, any anxiety may cause the high blood pressure. So the third one is abnormalities in renal or tissue autoregulatory process for sodium excretion, plasma volume, and arteriolar constriction. So if there is any abnormality, if there is any abnormality or the tissue regulatory process for sodium excretion, maybe the sodium excretion is not properly occur, and when there is an intake of sodium there is a passively water enters. Then when the passively water enters, so increase in fluid content and ultimately increase in the blood pressure. Or if there is arteriolar constriction, if there is a constriction of arterioles, so when the artery constrict, the blood pressure increases because the pressure putting on the vessels on the arteries are increased, which increases the blood pressure. Number 5 pointed deficiency in synthesis of vasodilating substances. Vasodilation is necessary for decreasing the blood pressure. If there is a decrease in the substances which causes the vasodilation, so the blood pressure increases. So it means the vasodilating substances are the prostacyclin, bradykinin, and nitric oxide. Prostacyclin, bradykinin, and nitric oxide, these three are responsible for vasodilation. If there is a decrease in bradykinin and decrease in nitric oxide and decrease in prostacyclin, so increase in blood pressure. Or excess vasoconstrictive substances, angiotensin 2, endothelin 1, these are the vasoconstrictors. So whenever they are released, the blood pressure increases. So this point is also important. And the last one is high sodium intake or lack of dietary calcium. If we are taking so much salty foods, then your blood pressure also increases. So we should take the healthy diet which has less sodium intake, or we should take such kind of which have more dietary calcium. So the alternate of sodium happen, and in this way the sodium content decrease, because when the sodium intake high, the passively water enters in the blood vessels and it increases the pressure, and the vasoconstriction occur and the blood pressure increases. So if there is, and these are the factors that causes the blood pressure high, which includes any abnormality in renal, angiotensin, aldosterone system, due to the insulin resistance, due to the hyperinsulinemia, if there is any disturbance in the CNS or autonomic nervous system, adrenergic receptors or baroreceptor, if there is increase in adrenaline, epinephrine, then there is increase in blood pressure or heart rate. Or if there is abnormality in the renal or tissue autoregulatory process for the sodium excretion, if there is less sodium excretion occur and the more intake, then passively water enters and the blood pressure increases. Or or also there is a definition, if there is a deficiency in the synthesis of vasodilating substances in vascular endothelium, like vasodilating substances like prostacyclin, bradykinin, and nitric oxide, if there is a decrease in such substances, then vasodilation occur and blood pressure decrease. Blood pressure decreases. But if there is a decrease in synthesis of these substances, the alternately blood pressure increases. Or if there is a high content of the vasoconstrictive substances like angiotensin 2 or endothelin 1, then the blood pressure increases. And the last one is the high intake of sodium and the less calcium intake food, like you have taking less dairy products like milk and the yogurt, and you're taking more sodium intake like fast food, etc., so your blood pressure may increase. May cause of death are cerebrovascular accidents, cardiovascular events, and renal failure. Probability of premature death correlates with severity of blood pressure elevation. If there is a extremely high blood pressure, so you may suffer with the cardiovascular event, cardiovascular damage, cardiovascular accidents, or the renal failure. So this is the pathophysiology. Pathophysiology in which it describes what are the secondary causes and what are the primary causes of the hypertension. Secondary causes, which are the specific cause, and the primary causes or essential causes are those which is unknown, which we don't know the etiology behind the primary or essential causes. Secondary causes due to the some kind of diseases. Maybe you may suffer with the chronic kidney disease. Maybe you have suffering with the Cushing syndrome, which is the genetic problem. You suffering with the aorta problem. You suffering with the sleep apnea, hyperthyroidism, pheochromocytoma. Pheochromocytoma is a cancer of the adrenal tissue. When there is a cancer of adrenal tissue, it means the abnormally high cells of adrenal cells, tumor cells are producing, which producing more epinephrine, or epinephrine ultimately increasing blood pressure. Primary aldosteronism or hyperthyroidism, these are the secondary causes, and the secondary causes sometimes are the drugs, the drugs that you are taking to decrease for the other conditions, like for the pain management you are taking NSAID, like diclofenac sodium, ibuprofen, aspirin. These are the common NSAIDs that we are daily you are using in our daily life. These may be responsible for increasing your blood pressure, so you have to keep an eye when you are taking such kind of painkillers. And other may be corticosteroids. Maybe steroids can also increase the blood pressure. Cyclosporins can increase the blood pressure. Erythropoietin and venlafaxine, these drugs are increasing the blood pressure. So the secondary causes are some kind of diseases or some kind of drugs that you are taking for other diseases. And the primary hypertension, for the primary hypertension, there are the other factors, which primary hypertension means which etiology unknown. The etiology unknown means maybe there is a problem in your renal angiotensin system, maybe there is a problem in the CNS or ANS, maybe there is a problem in the synthesis of the vasodilating substances, maybe there is a problem in the synthesis of the vasoconstricting substances, maybe there is a problem in taking the sodium, you are taking the high content of sodium. So these are the primary causes. Or due to the high blood pressure, the death may occur, and the death may be due to the cardiovascular abnormalities, cardiovascular events, renal failure, or premature death correlates with the severity of the blood pressure elevation. So our next point is clinical presentation. How we present this primary secondary hypertension. Patients with uncomplicated primary hypertension are usually asymptomatic initially. So if you have a primary hypertension and it's not a complicated one, then your heart conditions are normal. So maybe you don't feel any kind of the symptoms. Patient with the secondary hypertension may have symptoms of the underlying disorders. Patient with the pheochromocytoma may have headaches. Clinical presentation means how we can see the symptoms. In easy word, what is a symptom of the hypertension? So the patient with the pheochromocytoma may have headaches. Pheochromocytoma, here I mentioned the definition of pheochromocytoma means tumor of adrenal gland tissue, release of the too much epinephrine and norepinephrine. So when there is a high amount of epinephrine and norepinephrine, it means the blood pressure increases, and when there is increase in blood pressure, it may happen headaches, sweating, tachycardia, palpitation, orthostatic hypertension. Orthostatic hypertension is the rapid decrease in blood pressure, and the rapid decrease in blood pressure may lead to the death, which is very dangerous. So high blood pressure is lethal, but the rapid decrease in blood pressure is also very dangerous. So you have to keep in mind and keep an eye on your blood pressure. The high blood pressure patient should never be shouldn't be decrease the blood pressure so rapidly. The orthostatic hypertension means the high decrease in blood pressure which can lead to the death. In primary hypertension, in primary aldosteronism, hypokalemic symptoms of muscle cramps and weakness may be present. If there is a hypokalemic symptoms of muscle cramps and weakness may be present. If the aldosteronism, then hypokalemia occur. If you suffering with the hypokalemia means low potassium content, low potassium ions in your blood. You may suffer with the muscle cramps and weakness. Patients with the Cushing syndrome may be weight gain. If the patient is suffering with the Cushing syndrome, weight gain, polyuria, edema, menstrual irregularities, recurrent acne, or muscarinic weakness in addition to classic features. So, classic moon face, buffalo hump, and the hirsutism. Hirsutism means the hair on face or abnormal areas, and not the normal one. So hirsutism means when the hair growth on the face, on the chin, then it means the person may suffer with the Cushing syndrome. So the primary hypertension, sometimes the symptoms are asymptomatic, but the secondary hypertension, it depends on what is the cause of the hypertension. If the pheochromocytoma, then headache, then headache and sweating. If there is a Cushing syndrome, then there is a weight gain and weight gain, edema, menstrual irregularities, hirsutism, and if there is a pheochromocytoma, if there is a aldosteronism, then there is a hypokalemic cramps, hypokalemic associated muscle cramps and weakness. So the next heading is a diagnosis. Diagnosis is not our point of concern, but you should know we should check the high blood pressure with the instrument which is called the blood pressure checking machine or the sphygmomanometer. You have a sphygmomanometer in your home to check the blood pressure daily. So diagnosis should be based on average of 2 or more readings taken at each of 2 or more clinical encounters. So whenever the clinical data are obtained, so you have to take 2 or more readings and then take an average, which is that one is the right one. And the end organ damage sign primarily in the eye, brain, heart, kidney, and peripheral blood vessels. So this is also the diagnostic point. There is a damage in eye, brain, heart, kidney, peripheral blood vessel. It means the person is suffering with the high blood pressure. If you want, you can read the further the fundoscopic examination, cardiopulmonary examination, paravascular examination, patient with the renal artery stenosis, lab test. The next and the important heading is the treatment. How you can treat the blood pressure, which is the very important point. So first of all, you should know what is the goal of treatment. The overall goal is to reduce morbidity. It means the death and mortality. Morbidity means you have to decrease the morbidity and mortality. Morbidity means you have to decrease the disease, and mortality means you have to decrease the death rate by the least instructive means possible. So first goal is you have to decrease the morbidity and mortality. The second they are mentioned here about the JNC recommended goal BP less than 140/90 for most patient, and less than 140/80 for patient with the diabetes mellitus, and less than 130/80 for the patient with the CKD who have persistent albuminuria. So if the patient have diabetes mellitus, this is the important point. The blood pressure should be less than 140/80. Or if the patient with the CKD, the blood pressure should be less than 130/80. 140/90 if the diabetes mellitus. So you have to keep in mind, if the patient is suffering with the diabetes mellitus, then the blood pressure will be. सो नॉन फार्माकोलॉजिकल थेरेपी में आपने देखना है कि आपकी लाइफस्टाइल कैसी है. नॉन फार्माकोलॉजिकल मीन्स आप विदाउट मेडिकेशन हाइपरटेंशन को कंट्रोल करें. तो यू हैव टू keep an eye on your food. If you have high weight, then you should lose your weight. So the number one is weight loss. Number two is DASH plan. DASH plan is very important, which is the dietary approach to stop hypertension eating plans. So the dietary approach to stop hypertension, it's all a complete chapter. We can study it later, where how to बल्कि हम नेक्स्ट स्लाइड में डैश प्लान को डिस्कस करेंगे, इन विच वी कैन सी which food help to stop the hypertension. So we have to take some dietary approach to stop the hypertension. And which is the dietary approach to stop hypertension? It's eating plan. So we should take some kind of food, or we should avoid some kind of food to prevent the hypertension. Third one is dietary sodium restriction, ideally to 1.5 gram per day. So you have to take the sodium in the whole day approximately 1.5 gram. So if you are using the NaCl, sodium chloride, so 3.8 gram per day, or the sodium restriction will be 1.5 gram. And regular aerobic physical activity, so you should take some aerobic physical activity, moderate alcohol consumption, 2 or fewer drinks per day, or smoking cessation. So these are the non-pharmacological effects, like lifestyle modification. They are very important. Even when you are going even without medication, you can control your hypertension, and it is the first step to for your health. So there should be a weight loss, there should be DASH plan, there should be a restriction of sodium intake, there should be a low level of alcohol consumption, and the smoking cessation. So lifestyle modification alone is sufficient for the most patient with pre-hypertension, but inadequate for the patient with the hypertension and additional severe cardiovascular risk factors or hypertension associated target organ damage. So if there is a secondary hypertension related to the cardiovascular events, or other renal damage like chronic kidney disease, diabetes mellitus, so we have to take extra precaution and take some medication too. So the next one is the pharmacological therapy. Initial drug selection depends on degree of blood pressure elevation and presence of completing indication for selecting drugs. So first of all, we have to take some initial first line drugs. So first line options are angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, calcium channel blockers, and thiazide diuretics are acceptable first line options. So initially we give any kind of angiotensin converting enzyme inhibitors, angiotensin receptor blockers, or calcium channel blocker, thiazide diuretics. These are the four classes. These are the first line agent. Second line पे आपके आ जाती है beta blockers are used to either treat specific compelling indications or as combination therapy with a first line antihypertensive agent for patient without a compelling indication. So if the patient is suffering with any kind of the cardiovascular event, arrhythmia, and for the prevention of the myocardial infarction, we can use beta blockers, or in other case we can use combination therapy if patient is stage 2, so there is a need of the combination therapy. So first line agent plus beta blockers can be used. Most patients with stage 1 hypertension should be initially treated with a first line antihypertensive agent or a 2-drug combination. So combination therapy is given in the table. We can see here it's recommended for the patient with the stage 2 hypertension, preferably with the 2 first line agents. So if the patient is suffering with the prehypertension that we have already discussed, stage 1 hypertension, prehypertension can be resolved by the lifestyle modification, okay? But if the patient has stage 1, then you can go for the first line agent, and if the patient has stage 2, then you can go for the both combination therapy. There are 6 compelling indication, or if there is a compelling indication, then also you can give the combination therapy, where specific antihypertensive drug classes provide unique benefits. So we will discuss in the flowchart. Other antihypertensive drug classes are alpha 1 blockers, direct renal inhibitors, central alpha 2 agonist, peripheral adrenergic agonist, antagonist, alpha 2 agonist होगा और adrenergic antagonist होगा, because adrenergic increase the blood pressure and we have to take some kind of antagonist. And direct arterial vasodilators are alternatives that may be used for the select patients after first line agent. So first of all we have to give the first line agents. If the patient is not getting benefit from the first line agent, then we can go for the combination therapy. If the combination therapist has not given any kind of benefit to the patient, then we go for the newer drugs. So you can see here, this is the flow chart. So here this is the initial drug therapy choice. If there is no compelling indication, if there is a compelling indication. No compelling indications means if there is no any disease, no any kind of cardiovascular problems, then if you have stage 1 hypertension and stage 2 hypertension, for the stage 1 you can go for the first line agent, monotherapy using which is AC inhibitors, ARBs, CCBs, or thiazide type diuretics, or 2 drugs combination is the second option. So first of all you have to give the monotherapy, but in some patient with the stage 1 you can give a combination 2, but for the stage 2 you mostly give 2 drugs combination for most of the for most or preferably using. So AC inhibitor ARB with a thiazide type diuretics, or AC inhibitor ARB with the CCB. So you can give the AC inhibitors or ARB the one drug from both side. Um, ACE inhibitors and ARB with the thiazide diuretics, or ACE inhibitor and ARB with the CCB is the best combination. Beta blockers add when there is a compelling indication. When there is any compelling indication or the heart problem, then you can add the beta blockers. But mostly, the combination therapy include thiazide diuretics or ACE inhibitors, or calcium channel blockers or ACE inhibitors. The calcium channel blockers inhibitors combination are very common, and the most people are using this. This is a very important flowchart. In case of this flowchart says in case of the compelling indication. See, in case of compelling indication. So compelling indication includes heart failure, post myocardial infarction if the patient have heart failure with reduced ejection fraction, post myocardial infarction, coronary artery disease, diabetes mellitus, chronic kidney disease, recurrent stroke prevention. These are the compelling indication. 1, 2, 3, 4, 5, 6. So these 6 compelling indication required. Number 1, standard pharmacotherapy, which includes diuretics with ACE. Standard pharmacotherapy means the combination therapy. So we have discussed thiazide or ACE inhibitors. So diuretic with ACE inhibitors, and then beta blocker, and then add beta blockers. First of all, you give diuretics and ACE inhibitors, or if the patient is not getting benefit, then you add the beta blockers. The second is post myocardial infarction. In case of the myocardial infarction, so you have to give the beta blockers necessary. So then add ACE inhibitors or ARB, or then you add ACE inhibitors ARB when the for persistent hypertension, for persistent blood pressure. Coronary artery disease में भी बीटा ब्लॉकर्स आप दोगे. इस डायबिटीज मेलाइटिस में एसी इनहिबिटर्स और एआरबी. डायबिटीज मेलाइटिस के केस में एसी इनहिबिटर एआरबी है, और क्रॉनिक किडनी डिजीज़ में भी आप एसी इनहिबिटर्स और एआरबी देते हो. मतलब जो आपकी हार्ट से रिलेटेड प्रॉब्लम है ना, जैसे क्रॉनिक आर्टरी डिजीज़ हो गया, हार्ट फेलियर हो गया, मायोकार्डियल इन्फार्क्शन हो गया, उसमें आप बीटा ब्लॉकर्स ऐड करते हो. लेकिन जो आपकी स्कार्टिक मेलाइटिस है, क्रॉनिक किडनी डिजीज़ है, उसमें सबसे पहले आप एसी इनहिबिटर्स देते हो. रिकरेंट स्ट्रोक प्रिवेंशन में थायराइड डाययूरेटिक्स और थायराइड डाययूरेटिक्स विद एसी इनहिबिटर्स देते हो, जो स्ट्रोक प्रिवेंशन है. अब थायराइड क्यों? ताकि उसमें जो ब्लड जो उसके अंदर फ्लूइड accumulation हो रही होती है, उसको आप डिक्रीज़ करते हो. सो यू कैन प्रिवेंट द स्ट्रोक. ये स्टैंडर्ड फार्माकोथेरेपी है. सो इफ़ यू वांट यू कैन ऐड ऑन थेरेपी लाइक एल्डोस्टेरोन एंटागोनिस्ट ऐड हो जाएगा, या कोरोनरी आर्टरी डिजीज़ में सीसीबी और थायराइड डाययूरेटिक्स ऐड कर सकते हैं, और डायबिटीज़ मेलाइटिस में सीसीबी और थायराइड डाययूरेटिक्स ऐड कर सकते हैं. So you have to keep in mind that the first line agent is ACE inhibitors with ARB. If the patient is not getting benefit from the single therapy, then we can go for the combination therapy, which is ACE inhibitors or any kind of the thiazide diuretics, or ACE inhibitors or CCB. The most commonly CCB or ACE inhibitors combination therapy are using. If the stage 1, you go for the monotherapy, but you can give depending on the patient's condition. If the case stage 2, you should go for the combination therapy. If there are compelling indication, there are 6 compelling indication which is related to the heart. You add beta blockers and use the combination therapy with the ACE inhibitors. And this is the normal pharmacotherapy, but you can add in therapy by adding aldosterone antagonist in case of the heart failure, or the coronary artery diabetes mellitus. You can add the calcium channel blockers, thiazide diuretics with the ACE inhibitors. So you can see these are the comparative indication for specific drugs are evidence-based recommendation from outcome studies, existing clinical guidance. AC inhibitors, angiotensin converting enzyme, angiotensin receptor blockers, calcinum blockers are used. So you can see here in the table, they have mentioned the first line and other common antihypertensive agents. We will discuss these drugs in detail in the next video. Here we are emphasizing on the choice of drugs or the treatment plan, what drugs or what kind of class we use for treating the hypertension. So number one, there is you can see the class, drug brand name, usual dose and daily frequency. Yeah, you are taking the one medicine, one tablet or two, so it depends on the frequency. Trimetry, uh, so the first one is, we go from here, the loop diuretics. Loops diuretics include bumetanide, furosemide, torsemide. The furosemide is very common, so you can learn it with FTB. So furosemide, Lasix are very commonly used drug, so you can memorize the one from here, like Lasix, furosemide. The second is the potassium sparing diuretics, which includes amiloride dihydrochlorothiazide. uh, they have mentioned their brand names too. So you go for the generics and the brand if you want. Like furosemide brand is very common, so Lasix you should memorize it. And potassium sparing diuretics. The third one is the beta blockers. So beta blockers are two types: cardioselective and non-selective. Cardioselective means they are specifically act on the single receptors, and non-selective means they can act the beta 1 beta 2 both. So cardioselective means atenolol that acts on the beta 1, atenolol, betoxolol, bisoprolol, metoprolol. uh, uh, so for the beta blockers you should know the end name is lol. If there is an end name is lol, then it is called the beta blocker. Lol is recognition point for the beta blocker. So atenolol, betoxolol, bisoprolol. And for the non-selective you can use the propanolol. Propanolol is very common, so you memorize its brand into, which is Indrol use of the timolol. So the other one is the intrinsic sympathomimetic activity. Intrinsic sympathomimetic activity include acetobutolol, cardiolol, pindolol. We will discuss in detail these classification in the later, but we are emphasizing on the drug's name here. So up till now we have discussed the diuretics, which includes which includes loop diuretic, potassium sparing diuretics. Then we have discussed the beta blockers, which includes the cardioselective and the non-selective one. The cardioselective includes atenolol, butyrol, bisoprolol, and the non-selective includes propranolol, nadolol. Or the other one is intrinsic sympathomimetic activity. These drugs include acebutolol, which have intrinsic sympathomimetic activity. They are necessary to decrease the blood pressure too. We will discuss it later. Cardiolol and pindolol, mixed alpha and beta blockers. We are using mixed alpha and beta blockers, which includes carvedilol, labetalol. So these are very important. Which one are the mixed one? So labetalol you can learn from here. Betalol is a common one. Cardioselective and vasodilatory. Nebivolol is a vasodilatory too. Then the newer drugs includes alpha 1 blockers, doxazosin, prazosin, terazosin. So DPT, you can learn it with the DPT. It's a mnemonic for the DPT for the alpha 1 blockers. Uh, Doxazosin, prazosin, terazosin, these are the alpha 1 blockers, and they can also be used for the high blood pressure treatment. Direct renin inhibitor is a newer drug, aliskiren. Aliskiren is a newer drug. We are using this too. Sandra alpha 2 agonist. So alpha 1 blockers are using and alpha 2 agonists are using. So for this you have to learn the pharmacology of the antihypertensive drugs. So we will discuss these drugs in its pharmacology. And then peripheral adrenergic antagonist. Peripheral adrenergic antagonist, which includes reserpine, and direct arterial vasodilators, which includes minoxidil and hydralazine. Adrenergic antagonists include reserpine. So adrenergic antagonists, you can use it too. These are the new one. New one includes alpha 1 blockers, alpha 2 agonist, adrenergic antagonist, and direct and arterial vasodilators. So this is all about hypertension. What is the actual definition of the hypertension? We have discussed in detail in this video what is a systolic hypertension, isolated systolic hypertension crisis, what is the causes of the hypertension, the secondary hypertension and the primary hypertension. Secondary hypertension, whose causes are which is caused by the specific causes, like there is maybe a chronic kidney disease, diabetes mellitus, there is a heart problem, heart diseases, there may be a Cushing syndrome, if and also if you are taking some kind of medication which causes the blood pressure. And the primary causes are the primary hypertension, which is whose causes or etiology are unknown, like maybe the RAS is responsible for the hypertension, CNS disturbance in the CNS, disturbance in the ANS, abnormalities in the renal or tissue autoregulatory process for the vasoconstrictors and the vasodilators, deficiency in releasing of the vasodilating substances, and a problem in vasoconstricting substances, and if there is you are taking high content of the sodium and the less content of the calcium. So these are the primary hypertension causes. Then we have discusses the symptoms of the hypertension. The pre-hypertension symptoms are asymptomatic, that you are not observing any kind of symptom, but in case of the stage 1 hypertension, or the hypertension that causes secondary hypertension caused by the compelling condition like pheochromocytoma. Pheochromocytoma is a tumor in the adrenal tissue, so high amount of the adrenaline, so it causes the headache. If the pheochromocytoma, then there is a headache, sweating, and tachycardia. If there is also the Cushing syndrome, then edema, polyuria, weight gain, moon face. So these all are the symptoms of the hypertension. And here is a diagnosis. And diagnosis is not our point of concern, but you can see we should measure the hypertension with a sphygmomanometer, and we should take 2 to 3 readings, and then take an average in clinical counters, or also the sign of the end organ damage, and the others diagnosis by the fundoscopic examination, cardiopulmonary examination, lab test. And the most important thing we have discussed here is the treatment goal is you have to decrease your blood pressure in according to the guideline. If patient has less than 140/90 for most patient, Okay. Normally, the blood pressure should be less than 140 by 90. So 140 by 90 is the range. So normally the blood pressure should be less than 140 by 90. But if the patient has diabetes mellitus, then the blood pressure should be less than 140 by 80. And if the patient is suffering with the CKD, then blood pressure should be less than 130 by 80. So you can see 80 is the common factor in both case chronic kidney disease and diabetes mellitus. But for the diabetes mellitus, 140 is okay, but for the chronic kidney disease, 130 is okay. So you have to learn this. And the non-pharmacological therapy, which includes your lifestyle modification, your diet, um, your smoking cessation, your alcohol intake, uh, or mm, then pharmacology therapy, which includes your medication. First line agent ACE inhibitors, ARB, and the second line agent are the combination therapy, and you can add in beta blockers too. So ACE inhibitors with calcium channel blockers combinations are very common. Then we have discussed the name of the medication. We'll discuss the detail in the later video. So it's all about the hypertension. I hope you like my video. If you have any question, you can comment below. You can also discuss your personal medication plans about controlling of the hypertension and your lifestyle changings in coming too. So kindly like my video, subscribe my channel, and never forget to click on the bell button. Thank you.